1. Yeah. Okay, MH2. Okay. Okay. There's a mod. How's everyone doing? Rose, you're there already. Okay. I got a smaller one, so we'll go for that one. Oh, not that one. That one. Feature more of Miami Beach. What do you think, Zanab? You think it's better? Oh, Ahmad, can you talk, Ahmad?
Huh?
There's Zanab, right?
Yes, sir. It's Zainab.
How you doing today?
Fine, thank you, sir. How are you?
Good, good. No camera today? Miami Beach. What do you think, Zanab? You think it's better?
Let me see.
Not yet.
Okay, sir.
I always say not yet, giving you a little hope. Oh, Ahmad, can you talk, Ahmad?
Huh?
I hear some audio in the background. I think you're playing it. How you doing? You're playing probably the YouTube channel. Good. Welcome, Dr. Ahmad Fawad Pirzad from Afghanistan Neurosurgical Society. We're trying to get that Afghanistan Neurosurgical Grand Rounds going, hopefully someday. What do you think of that, Rose? Or Zanab? What do you think of that? Welcome, Dr. Pillai.
I think it's good.
Okay.
Mm-hmm.
What do you think of that, Rose?
I think it's great.
Okay, you can hear me, my voice good? This is Zanab, right?
Yes, sir.
Yeah, I can hear your voice good, but I think you're playing something else on your computer because I can hear a delayed sound. You probably got YouTube on too.
Yes, I have the YouTube on. Let me log out of it.
It doesn't bother me because you're going to be muted. Right now, you're not muted, right? No, you're muted now, but the sound won't come through.
I was wondering where was the noise coming from, but I just noticed that it's the YouTube.
Yeah, it's on YouTube too, but it's delayed.
Mm-hmm.
It's like like television delayed. That's
Yes,
allowed the censors to cut out stuff that is untoward. I don't know if the term in the medical sense.
it's like a form of addiction, right?
I'm sorry, what's that?
For the YouTube, is it a form of addiction? That's the difference between the YouTube and the
No,
live.
it's the same. It's the same as what we're doing right now. It's on live actually on YouTube. Someone's raising their hand. Come on in. I guess I gotta let people in here.
So I have a question. The Yemen webinar, do we have a recording of it?
Yeah, they're all on the YouTube channel
Okay, sir.
for Neurosurgical TV. Do you belong to the YouTube channel?
Yes, sir, I do.
Takashi, how you doing?
I'm fine. Yeah, it's good. Good evening.
It's good to see you.
Good to see you. What time? From when?
Well,
Did you begin 9 o'clock?
15 minutes.
In 15 minutes. Okay.
Okay.
I'll be back. Yeah. China, in China time, 8 p.m.
Yeah.
Yeah, okay. So yeah, I'll be back.
9
later.
o'clock Japan time, right?
9 o'clock. Okay.
So how you been? Oh, I guess he's got to go. How you been?
Been?
How
Yeah.
have you been?
I've been.
How are you?
Yeah, I'm very fine. It's good, but a little bit busy because of the neurosurgery, neuro-oncology meeting last week.
Okay. Yeah, I want to talk to you. I'll talk to you privately. Okay. Maybe after, or please message me because I have some important things to tell you.
Okay. Okay.
Good stuff.
Okay. So.
Because I want to come over there to Southeast Asia. I want to come to Southeast Asia.
Oh, okay.
I've never been there. Singapore, Thailand.
Thailand.
I've never been there. I would like to go there. Japan. I would like to go. I would like to go meet Dr. Ben in China. You know.
Yeah. Okay. We welcome in Japan and some during my way of neurosurgical journey.
Yeah. Well, the day's getting closer, Takashi, when we can go to a place like Mongolia. And do a Mongolia Grand Rounds live.
Oh, Mongolia.
You and me.
Mm.
I'll be the tech guy. I'll be hold up the lighting and the camera.
Okay.
And you do the announcing.
Mm.
Hello, Muscat. I'm Mahesh Pillai. How are you, Mahesh? If you want to speak and say hello, you're welcome to, Mahesh. From Muscat. Muscat. Where is Muscat? Is that in the Middle East somewhere? Or India? Does anybody know?
Middle East, Muscat is close to Dubai or.
Oh, it is. It's in Saudi.
Yes. Middle East, Dubai, Qatar. Mm.
Good. We're getting some people.
Mm.
Oh, the capital of Oman. Okay. You were right. Takashi. Oh, Ben, how you doing? Here's Ben.
Hello, John.
Hey, Ben, how you doing?
Hi, fine.
Well, let me take my pen off here.
Mm-hmm.
How many bypasses today?
We are just recovering for the pandemic,
Oh, that's right. You're on strict quarantine, right?
Yes.
Still?
Now, tomorrow we will go back to work.
Oh,
actually, last 2 weeks I already performed some operations.
Oh, okay.
But we still live in a hospital.
Yeah, Dr. James Liu, we're going to do a series with him. Do you think we should translate him into Chinese? Do you think he has a following, or he would get people to watch him?
I beg your pardon?
Do you think we could get people to watch Dr. Liu? We're going to do a series with him on Skull Base.
Uh-huh.
You think we should televise it into Chinese, or you don't think there'd be a demand for that?
Actually, we can arrange some translator. No
Yeah,
problem.
I would appreciate that because
Mhm,
he's a
mhm.
very good lecturer. And
Mhm,
I understand he might come over to see you.
mhm.
So yeah, I would like to televise with him in skull base. I think he wants to do, he may want to do cerebral vascular, but once a week. And you just have, if you can have a resident come.
You mean James Liu?
Yeah, James Leo from
Yeah.
from
I know
Rutgers,
him.
Rutgers.
Yeah.
Yeah. He said he may visit you in
Yeah.
a couple of months, right?
Yeah. Yes.
Yes, that's the one.
Mhm.
So I'll let you know.
Okay.
How was Yuha? Have you seen Yuha? Heard of Yuha?
Yeah, he is still in Finland, I think.
Oh, he never made it to China, huh?
Yeah, he will stay in China for 4 months every
Right.
year. Yeah.
Oh, now he's back in Finland.
Yes.
Oh, okay. 'Cause I don't bother him because,
Mhm.
he will get in touch with me, I think, if he wants to do something.
Yeah.
So, because so many people.
I'm not in the panel, I think. You.
Yeah, I can't see your camera. Yeah, no, you're in the panel. I see
Okay.
you. I see you. Your camera's
Okay.
not turned on there. I hear you. I see you. You're in the panel. Yeah. Oh, okay. Oh, I'm sorry. You may be right. Okay.
Yeah.
You may be right. Yeah, I thought I
Yeah,
had.
yeah.
I thought I had you admitted. There you go. Okay.
Yes.
There you go. There you go.
Yeah.
Yeah. So, yeah, we've been doing a lot of broadcasting. We did from Venezuela for
Mhm.
the first time, and doing it from Cuba in about a couple hours. Cuba grand rounds. They don't.
Yeah.
They don't come on the internet much. It's the bandwidth is not good. It's getting better though. It's getting better in Venezuela and certain parts of the world. Now, in China, is the bandwidth pretty good if you get away from the coast? Is the Wi-Fi pretty good on the interior of the country of China?
You
Wi-Fi?
mean
Wi-Fi? Yeah.
No problem.
It's good.
Yeah.
Yeah, because there's some parts that's not good.
Yeah.
In some parts of Mexico, it's terrible,
Uh-huh.
terrible, and some parts of Cuba.
Actually, if you use now 5G is also more and more popular.
Yeah. I
Yeah.
can see it around the world getting
Mhm.
better. I can see it all the time. In the old days, it was very difficult. We used a platform called Google Hangout. Did you ever use that? It was a predecessor of Zoom. No, you probably never used it.
No. Google was banned in China.
That's right. Oh, that's right. That's right.
Yeah.
But even here in this country, it was hard to get doctors to try it.
Mhm.
They didn't even want to try it. But once Zoom came, of course, everyone understood what it was because you had to learn. There was no choice. Okay, we're waiting for everybody. Juan Lee.
Takash, how are you?
Oh, Nick's here. Okay, Nick Borg, associate of Dr. Lanzino.
Hello, Beam.
Hi.
I'm fine. I'm fine. Yeah, I'm fine. Nice weekend.
Nice weekend.
Yeah.
Hey, Nick. So
Yeah,
we
I don't know how you
rouse,
do.
we rouse you out of bed. No, you're not getting out of bed. It's in your day.
Oh yeah, it's the middle of the day here. It's early afternoon in the United Kingdom.
Yeah, Nick, I'd like you to meet Dr. Bin Zhu. I don't know if you met Ben from China.
Two previous
Hello,
webinars.
hello,
How you doing?
Nicholas.
Good to
Fine.
see you.
He worked
Good
a
to
lot
see
with
you.
Dr. Lanzino at Mayo.
Yeah, I just finished my fellowship at Mayo. Had a fantastic time, and I'm heading to Nebraska next as assistant professor.
Ah,
Yeah,
great.
He's a
thanks for
friend of
having me
Zoom
today.
too.
Yeah,
We gotta start something, Nick, over there.
sorry, John.
We gotta start something over there.
I
Broadcast.
hope so. Yes, I hope so. There's lots of potential and lots of people who are very interested. So
Keep it in mind. Keep it
yeah,
in mind.
hopefully we can work together.
Yeah,
That'd be great.
I'd like to do that. I was just telling Ben, we just broadcast Venezuela for the first time yesterday, and Cuba we're doing for the second time this afternoon after this webcast. So
Very impressive, John. Very impressive.
yeah, it's fun. It's
Well done.
fun. You get to meet people like Ben on
Yeah.
the other side of the world. And Takashi, oh, this is Takashi Khan. He's a Japanese neurosurgeon.
Good evening. Good evening. I'm
Nice to
Dr.
see you.
Kong
How you doing?
in Japan. And I'm fine. And Tokyo is very hot today.
Oh, really?
It's hot there, huh? Not like Miami.
Uh,
It's scorching.
oh,
Okay, Juan Lee, we're still waiting for, right? You gotta wait to get a hold of him, Ben, just to make sure he's coming.
Yes, I will call him.
Yeah. Yeah, as a coordinator, you always get nervous that people aren't gonna show. The principals aren't gonna show. There's a doctor from Afghanistan here. Fawad, can you speak? Fawad? Neurosurgeon from Afghanistan. He can text. He's saying hello. Yeah, I'll write to him too. Okay.
So, John, just while we're waiting, do you want me to keep an eye on the chat and the Q&A? And
Oh yeah, that'd be great. Let me make you administrator, a co-host. I mean,
okay, cool. Thank you.
yeah, it shouldn't be too busy.
Yeah, no problem. And are you okay with me interrupting the speakers if there are questions, or are we going to do questions at the end of the talks?
I think it's up to
To
Ben.
the end of the
It's up to
talks,
Ben.
yeah.
End
Yeah,
of the talks? No problem.
Yeah.
Sounds good.
Yeah.
And how many talks have we got today?
2.
Two. Okay, fine. So roughly like half an hour per talk with some questions in between.
Yeah.
Sounds good. Thank you.
I think Juan Lee's going to moderate, right?
Yes, Yanni is
Yeah,
a log
so,
on. Yes.
Yeah, I'm going to introduce him. Maybe in the future, Nick, you could do some hosting and stuff.
Yeah.
Yeah, let me email. Juan Lee. Oh, here's Lima. So I guess we can introduce him first. Can you introduce him? I guess Lima is here. Lima is here. The first, one of the speakers is here. Oh, there's one L. Okay, he's here. One Lee. Hello, Dr. Lima.
Hi, Dr. Janet.
Welcome.
Thank you. Thanks for hosting.
And there's one Lee. How you doing? Good morning. Good
Hi,
morning.
yeah. Hi, Dr. Bernard, John. Yeah, actually, yeah. I think now it's 8 p.m. and we should start our webinar. But
Okay.
I'm still outside. So I told Professor Xu and I think please invite him as the first moderator for.
Okay, who should I, Dr. Lee? Oh, who did you say?
Dr. Xu Bing Xu as the moderator for the
Ben,
first
okay.
speaker.
Yeah, of
Bing,
course,
yeah.
Ben. Yeah, I know Ben.
Bing, yeah. Okay.
Okay.
Thank
Okay,
you.
Ben, you ready? Okay, here we go. Okay. Okay. And you can just structure it the way you want to structure it, Ben. Okay, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning, and from Miami Beach. It's Dr. John Bennett for Neurosurgical TV. We have another of the bi-monthly webinars from the Chinese Neurosurgical Journal, and it's being moderated by famed neurosurgeon from Shanghai, Dr. Ben Zhu, and he's going to run the proceedings. Welcome, Ben.
Thank you, Professor Dr. Zhang. And so now let's give the time to Dr. Lima from Tiantan Hospital. And his topic is quantitative susceptibility mapping as a non-invasive tool for CCM phenotype and hemorrhage or seizure risk assessment. Let's welcome.
Thank you, Professor Xu. Is my slide showing on the screen here?
Yeah, did you want to get it on presentation mode? There you go, perfect.
Thank you. So thanks for all the hosts here and all the audience. And my name is Lima from the Department of Neurosurgery at Beijing Tiantan Hospital. And today my topic will be focused on the quantitative risk assessments for the cavernous malformation clinical events, including hemorrhage and seizures. So first, a very brief introduction about the cavernous malformation, or in some parts of the world, they call it cavernous angioma or angioma just for short. So these are the vascular disorders with thin and leaky walls in a Malbury shape. And on the MRI, usually they presented with hyperintensity or popcorn with mixed signals within it, just like the figure shown here. And the incidence were estimated to be 1 out of 500, but actually most of the patients were asymptomatic. And the most common presentation, including seizure, hemorrhage, and neurological deficits. And in some cases, they showed they are associated with the developmental venous anomaly. And when these patients are referred to our clinic for CCM, here are some questions about. Here are some questions that patients might be concerned, and that will be the start point of our study. And the first question is whether they need a treatment or not. Before we can get an answer for that, we need to help the patient to understand what is the risk for treatment. And it will be an open surgery or stereotactic radiosurgery or even laser ablation recently. Or alternatively, what would be like if they choose to follow up without these invasive treatments. Usually, the patient would like to have the exact number or ratio to understand the risk. So the most common and well-described way of risk assessments is based on the prior hemorrhage history and the CCM location. This is an individual patient level meta-analysis of CCM cases from actually 6 studies from Scotland, France, and North America and East Asia. They showed a higher future hemorrhage risk in patients with brainstem lesions and with hemorrhagic presentation, just like the red line shown here. And another point of clinical importance is that with the future hemorrhage events seems to mostly occur within the first 2 to 3 years, just like the curve line here. And they call it a temporal clustering with an average of hemorrhage risk of 2% per month in the first few years. And that decreased by 2-fold after that. Just like a volcano, there will be some falling activities right after an eruption, and it gradually goes to silent mode afterwards. And an overall hemorrhage risk during the first 5 years accumulation is shown here. And depending on different location and presentation, but actually not all the CCM hemorrhage is lead to catastrophic or irreversible neurological deficits. As we can see here in the right table, only about 40% of the CCM hemorrhage got a full recovery. And actually 80% of them got a favorable outcome with no or only mild disability. But only very few studies have focused on that. Actually, only 2 or 3 studies have the data on that. And this is a study from my colleagues, specifically on brainstem CCM with 700 cases. That's a large number during a 10-year study period. And most of the patients had a prior hemorrhage history or presentation, about 90% of them. And also a temporal clustering was observed. Within 1 year. And after that, followed by a rapid decline to the overall level. And this colorful image is to show the modified ranking scale change at different time points. As we can see, most of the patients had a prior hemorrhage history, and half of them had an MRS score of 2 or more. And after a follow-up period of 4 to 5 years before any treatment, only 20% of them remained in neurological deficits. These patients are actually the target of our treatments, whether they could be improved if they choose to be treated. So my study group come to think about how to predict the neurological outcome after the hemorrhage for every single patient with CCM when they come to see us at different time points or with different condition. We use a nomogram like here with some common clinical and imaging features of a patient. We could get a point for each feature. For example, if we would get a 25 points if the patient had a 2 prior hemorrhage history, and a 10 points if the patient get a brainstem lesions. And by sum up these points for each feature together, we got a total points like here. At this point will correspond to a probability of disability, which is with an MRS score of 2 or more within the first 2.5 years of temporal clustering. As is the same for the disability of MRS score of 3 or more. And the accuracy for this tool is 87% in an independent validation cohort. So with a relatively specific estimation of the morbidity for each patient, if they choose conservative follow-up, and it can be compared with the risk of surgery. And the score here is developed by Dr. Michael Lawton, also based on some clinical and imaging features, including size, hemorrhage period, and so on. We could get a total point for each patient. As we can see, in patient with a point of 5 or lower, 80% of them will get an improved or at least better outcome after the surgery. But in the patient with a point of 6 or higher, only half of them actually remained in the favorable outcome, and 100% of them will get the condition worse. So but this is one of the best surgical results from some master neurosurgeons, and this risk can be different from site to site. And this is what we can do with the traditional CCM features. But when we see there has been molecular classification in brain tumors almost 7 years ago, so we might ask when we could have some advanced risk assessment tool for CCM with better molecular or imaging biomarkers. And here's a very interesting study to correlate the genetic mutation of the CCM and the location feature in multiple CCM cases. And this study from the University of Essen, the multiple CCM were classified into 2 groups. One is called the scattered type, just like the imaging shown here. The lesion of the CCM is somewhat random and not associated with venous anomaly. And these cases were identified with the CCM gene mutation with very few exceptions. While another type of multiple CCM is called the cluster type. They actually found to be associated with venous anomaly, and the lesion is right along the venous anomaly. And for these cases, the genetic screen is always negative. So it is a very good example to show how we can correlate the genetic background of the CCM and their imaging features. And on the other hand, it shows that the CCM might form either after a gene mutation or along a venous anomaly. In the past 2 years, several studies with better sequencing technique revealed some novel somatic mutations in sporadic CCM cases. And the most common mutation were the PI3CA and MAP3K3 mutation. The PIK3 mutation were reported to be found in 40% of CCM cases. These are all actually sporadic, used to be the sporadic CCMs. And this is a paper from the New England Journal, and this ratio were reported to be higher, around 70%, and another case published on Nature. So the investigator from the Xuanwu Hospital, also in Beijing, revealed either the PIK3 mutation and the MAP3K mutation were found in 90% of the CCM cases, with 40% of them were PIK3 mutation, and the 40% were the MAP3K mutation, and another 20% with co-mutation of the 2 genes, as the red arrow showing here. And my colleagues at Tiantan also reviewed the MAP3K mutation, and this mutation was more commonly found in CCM with Zabramsky type 2 CCM, just the popcorn lesions right here. And the exciting findings of these novel mutations is that they might associate with the future hemorrhage risk. As you can see here, the PIK3 mutation were associated with higher hemorrhage risk, just like the red line shown down here. And the MAP3K mutation were associated with a relatively better outcome. And the co-mutation is somewhat intermediate between them. Although this is from the study of a small sample size, it actually implies the genetic background is associated with the clinical and imaging features of the CCM. And the most recent finding indicate that the PIK3 mutation were found both in the associated venous anomaly and the CCM lesions, while the MAP3K were only found in the CCM lesions. So the second hit hypothesis goes like the CCM loss of function or MAPK3 gain of function would contribute to the CCM formation, while a hemorrhage or size enlargement would be something after the PIK3 mutation. These novel genetic mutations very likely to serve as molecular signature to understand the CCM progression and stability. However, for the patients, they actually need risk assessment before we can get these tissue samples. So we need non-invasive tools to distinguish these CCM with different stability features. Then we come to the next slide. One of the non-invasive biomarker is the MR imaging with a special sequence called the QSM, which is quantitative susceptibility mapping. To test whether it will be used as a biomarker for CCM progression, we can actually track the change during a long-term follow-up to see whether the QSM feature and the change would cooperate with the hemorrhage or seizure. And Dr. Isama Watt from the University of Chicago is conducting this in a multiple center study group. And my group also registered a study, we call it CRESS. We actually collected 90 CCM cases with QSM and with tissue sample from 2/3 of them. And this is what the QSM looks like. It shows a good correlation between the QSM susceptibility value and different iron compartments. So it is sensitive marker for CCM progression, and its change during the CCM follow-up would cooperate with the CCM hemorrhage and enlargement of the lesion. And when we merge the QSM and our ordinary T1 weighted image together, we find actually there's an extra lesional area, as is shown here in the blue circle, with increased QSM value. That is outside of the lesion and the paralesional rim, which is shown in red and yellow, respectively here. Then we move forward to see whether these imaging features could represent some CCM clinical features. In patients with supratentorial CCM involving the cortex, we further divide the patient into two groups, one with seizure and the other without seizure history. In patients with seizure, like the cases on the left, we observed a higher QSM value in this paralesional area and a larger area of the abnormal QSM beyond the hemosiderin ring. And the right case is just a reference without seizure history when we perform the QSM. Then we quantified and compared all the other cases. A cutoff of 0.6 for the paralesional ring is proposed after we adjust the CCM location because some parts of the brain might be sensitive while the other might be insensitive to the iron. It is somewhat interesting that this hemorrhage overload is not observed in most CCM with symptomatic hemorrhage or Zabremski type 1 lesion. So if this area with iron overload is more correlated with seizure, it might be used to help us to design a better surgical resection area beyond the lesion in cases with seizure. And this is an easy merge of the QSM into intraoperative navigation, but we still need to wait the follow-up data to see whether it could be helpful for better seizure control. And apart from the surgery, studying the correlation between the imaging markers and the clinical follow-up, the iron overload measured on the QSM also provide a method to quantify the leakage from the CCM. So we continue to see the molecular features of them. And the preliminary data of proteomics suggests increased protein expression of PI3K signaling CCM with low QSM, and protein expression of MAPK signaling were increased in CCM with high QSM, as is shown here on the right. And our ongoing project is to see the correlation between the gene mutation and the QSM features. We try to identify the differential expressed protein of CCM with different QSM within the PI3K and MAPK signaling. Then we got the REC and the PAC kinase, and their role between the two signaling has been reported actually in some malignant tumor. And the CCM with iron overload outside the lesion, the expression of the REC and PAC seems to be lower. We also use the protein interaction network to see some downstream of the REC. And we find a decreased expression of this pod XL, which is the podoxylin, along with the decline of the REC and CDC42. In normal endothelium, the pod XL is expressed along the endothelial apical, which is around the lumen of the vessels. And the green fluorescence indicate on the right here, indicate a knockout of the CDC42. And we can see in the cells with CDC42 knockout, the pod XL stained in red is not along the lumen and showed malformed vessels. But there is still some lumen formation in some vascular cells without CDC42 knockout. This endothelial abnormality is actually observed in our CCM samples. It is called loss of endothelial polarity. Here we use the CD31 to mark the endothelial cells of the vessels, which is shown here. And we use the PODX cell to reflect the polarity of the endothelial cells. And in normal vessels, the PODX cell is stained along the vascular lumen. So both green and red should be here. However, in CCM with low perilesional iron load, there's still some normal vessels with polarity, as is here with the arrow. But we can see some of the vessels, they only express the green with CD31, the loss of the red staining of PODX cell. And if we move over to see the CCM with high perilesional iron overload, we see most of the vessels are actually loss of PODX cell, which indicate loss of the endothelial polarity. So if we move backward one slide to see the interaction between the PI3K and the MAPK, although the CCM would be gain of function of either PI3K or MAPK or both, actually the activity of the REC at its downstream, maybe the PODX cell, might affect how these mutations would interpret on the vascular phenotype and iron leakage. And that would correspond to hemorrhage and history and seizure. So a very brief summary to conclude my topic. We need to provide a quantitative and individual assessment to help the patient understand their condition and risk. And some recent findings of the genetics provide more chance for us to see the CCM pathophysiology. And with big data from imaging and molecule, we could have better biomarkers to help the clinical decision making. And last, I would like to thank our study group under the leadership of Professor Jiao and our neuroradiology colleagues and postdoc and PhD students who devoted themselves to the study. And that's all for my topic, and any question will be welcome. Thank you.
Okay, thank you, Dr. Actually, in Chinese, it's Ma Li.
Yeah.
Thank you.
Thank you.
So any questions?
Don't be shy. Don't be shy. Now's your chance. Everybody's
So do you
quiet
check the, do you do the, this kind of gene examination routine for every CCM case?
So actually from the aliens, Angelman aliens, which is a non-profit organization, they actually advise not all the patients actually, especially the multiple CCM cases, not all of them need to underwent a genetic screen. Just like the slide I have shown with the MRI scan, if the multiple cases is actually, we can find the venous anomaly and the lesions are actually located right along this venous anomaly. Most of them actually are negative for the CCM gene. We try with more somatic genetic mutation in the future to see whether they have these somatic genes. And on the other hand, if the patients are actually just the multiple cases randomly, not a lot, and no venous anomaly was found, they're actually positive. So for these patients, it's very useful to perform the gene screen.
Okay. Nicholas, do you have some question?
I'm keeping an eye on the chat or the Q&A. I don't see anything. I guess a quick question from me would be what are the future directions of your research? It's been really interesting to hear what you've presented. Where do you anticipate taking this next?
Thanks for your question. So the direction of my study is actually divided into two directions. So the first part is to still to observe the changes of the QSM during the follow-up to see whether they can actually correlate or predict the severe or future hemorrhage happening. And that will be developed biomarker, imaging biomarker, non-invasive biomarker for us to understand whether these patients are more prone to hemorrhage or seizure in the future. And then for the high-risk patients, we can advise them on surgery. And another direction is to see whether these biomarker can correlate with the molecular features or also some genetic mutation. And if that is the case, then it says that these imaging features are also very good markers for these to observe these molecular changes.
But one question is, one problem is that this kind of normally it's a multiple lesions. So what kind of spatial lesion you would recommend to treat if you find this kind of mutations?
Oh, for the
Depend on the size or some spatial. Do you have some spatial recommendation?
Actually, for the multiple cases, we didn't perform the QSM. Yeah, and the current enrollments of these cases are actually somatic cases with the solitary lesions. And because for the multiple cases, although we can also perform the QSM scan, but we don't know which one would be more hazardous in the future. Yeah, it's hard to see because for a single lesion, it might be easier to get a start. And if that works, then we move on to another complicated scenario for the multiple cases. And I think that would be more optimal.
Yeah.
If you're interested in collaborating, I'd be happy to contribute. So please get in touch, and we'd love to help out if we can.
Oh, thank you. That would be good to discuss with it together and to share some very interesting findings.
Thanks.
Making a connection. Okay, Ben. Dr.
Okay,
Teo is
so Yuan Li.
No, Wan Li. I think he's outside.
I'm hearing, but yeah, it's so I think
Okay.
the second speaker, Dr. Mario Teo, he's supposed in he's in Bristol, UK, and I'm not sure if he make mistake about the time zone, because should be.
No, he's here. He's here.
He is here.
Oh,
yeah.
really? Oh,
Yeah,
sorry. I'm not. I don't know. I just
So now let's give the time to Professor Maria.
Sorry.
Teo.
Yeah.
Yeah. Okay. Let's move on.
Ah,
That's a strange introduction, right, Dr. Teo?
Yeah.
yeah, Dr. Teo. Hi.
Hi.
Sorry, I'm still outside. So please, I think now you can give your talk, right?
Sure, my pleasure. I can start sharing screen. Yep.
Thank
Today,
you, Dr.
Dr. Teo from UK will talk about the new grading system of Moyamoya disease, right?
Yep, that's the plan. Yep.
Okay, please. Wonderful. Thank you.
All right. So Yeah, good morning, good evening, good afternoon. I know this is linking in from different parts of the world. My name is Mario Teo. I'm consultant neurosurgeon here in Bristol, and thank you for the honor. Some of you would have heard this talk. I know Professor Xu Bing has heard this talk before. Essentially, I think this is the ideas about trying to come up with the grading system for Moyamoya disease that's more, I guess, practical, just like the Spätzle-Martin grading system for AVM. So the topic of my title, Predictive Modeling for Post-Bypass Stroke Risk, and we call this the Stanford-Berlin Moyamoya grade, and it's a collaborative work between different centers, including California, Stanford, here in Bristol, and also some of my collaborators in Johns Hopkins. So Suzuki stage, as we are all very familiar with the Moyamoya work, it's over 60 years old, and it's based purely on radiographic grounds. No, it doesn't really correlate with the disease severity. It doesn't correlate with the patient's symptomatology, and it doesn't correlate with the postoperative surgical stroke risk. So as a result, we think there is a need for a more contemporary grading system for Moyamoya disease to address those problems. So the way we work on this, we define major strokes are strokes that occur after bypass, which resulted in change in a pre-existing MRS, modified Rankin score. And also it has a corresponding radiological change, meaning either a DWR infarction or a hematoma. So we use the three parts to this talk. We use the derivative cohort to come up with the Stanford-Berlin Moyamoya grade from the cohort in 1991 to 2014. These are patients from Stanford, nearly 800 patients with over 1,000 bypasses. And then we have a validation cohort, which include patients from 2015 to 2018, again from the same center, and nearly 300 patients. And then we use the artificial intelligence model and machine learning to come up with the predictive modeling to see how good the models can predict postoperative stroke risk. So there is the background to this work, which is the Berlin Moyamoya grading system that was proposed by Professor Wykotzy in Berlin in must be about 8 years ago. So essentially the ideas behind it is to correlate with patient symptomatology. And they have three components to the Berlin grade, with initially the angiographic finding, stenotic occlusion with Moyamoya vessel, with intracranial compensation or intracranial extracranial compensation. They get different scores. So intracranial compensation means either from PCA to MCA or ACA to MCA collaterals. For extracranial to intracranial collateralization, that means from either medial meningeal or from the occipital artery. And in some patients, there is the pre-existing STA that's going into the intracranial collateralization. And a lot of them also has the skull-based collateralization from the ophthalmic artery and the ethmoidal artery. Now, MRI score, they have either no ischemic changes or with ischemic changes. Ischemic changes can also include previous old ischemic change that leads to atrophy. Then they look at the Pseudovascular reserve, steel or no steel. So this is the background Berlin grade. So from the derivation cohort, like I said, nearly 800 patients from 25 years of data. So there were 52 major strokes. That means the major stroke risk is 6.8% per patient. And the stroke risk after the first bypass was 5.3%. So 41 out of 769 patients had a major stroke after the first bypass. And for patients who had second bypass, 12 out of 467. So this is saying not all patients have bilateral bypasses. So you can see majority of them, if anything, had so 467 out of 769 had bilateral bypasses. That means there is still about 30% of them who has a unilateral bypass only. Now, this is the breakdown of the cases from 1991 to 2015. You can see initially it was kind of slow, and then up until 2006 onwards is about 100 cases of bypasses per year. And these are different colors. The maroon colors are for the adult cases. Purple colors are for the pediatric cases. So the risk factors that we analyzed, we look at all the different risk factors that has been proposed by various previous authors, and also the different factors that we think could be related to post-op stroke risk. And we look at the patient's demographics, the age, their past histories, their presentation, whether it's ischemic or hemorrhagic presentation, Suzuki staging, the historical one, and see whether there's a role for Suzuki stage. And the 3 scores, and we make modification to the Berlin grade. So for the angiographic score, this is the grade 1, where there is sternal occlusion. Grade 2 is when there is IC collateralization. You can see PCA going into the MCA, or PCA going to the ACA. And grade 3 is when they have extracranial to intracranial collateralization. So this comes from the either the middle meningeal. Most of them come from the middle meningeal or the STA. Some of them come from the occipital artery through the bone and go into the brain. Whereas with the MRI scored, what we do, instead of having stroke or no stroke, we also included the third categories, whereby if the patient had a stroke within 30 days of having a bypass, so they get another point, so there'll be 2 points if they have a new infarct within 30 days of bypass. Hemodynamic reserve, instead of just looking at still or no still, this is a xenon scan. So they would do pre and post acetazolamide challenge. So red means blood flow increase, blue means blood flow reduce, white means there's no change to the blood flow. So under normal circumstances, in patients with good augmentation, the blood flow should increase. Therefore, you can see in this case, they very symmetrically red. Whereas in this example, after acetazolamide, when you do the subtraction graft, you can see there is blue on the right frontal or right MCA territory. So what this is saying is there is steal phenomena in the right MCA region. So there is also a third possibility whereby even though the patients do not have steal phenomenon, but they do not augment. So that is what we call impaired cerebrovascular reserve. So this is the modification that we've made. Angiographic score still the same as the Berlin ones. With the MRI score, we added a DWI positive infarction, and the hemodynamic reserve, we included impaired augmentation. So as you can imagine, these studies include patients from 1991 to 2014. So it covers over 25 years of practice. So there has been different modality used to study the cerebrovascular reserve. So initially, xenon scan, and then towards the later part, we are now more so using either SPECT or MRI perfusion scan with and without acetazolamide. So all the different modalities, as long as they will give us some sort of ideas of whether there is steal or impaired augmentation, then we are able to give them this score on the hemodynamic reserve. The patients up to age of 70, and you can see there's the bimodal peak. These are the Western Moyamoya population. So whether it's the same as the Eastern Moyamoya population, in theory, there will be a lot of similarity. It might not be totally the same. So we know that Moyamoya disease is more common in the East, in Asia, China, Japan, Korea. So the incidence is 10 times more common. So here we're looking at, in the West, we're looking at about 1 per million, whereas in the East it's about 10 per million, so 10 times more common. But nevertheless, this is the data from the West that we are proposing, and hopefully we can work collaboratively in the future. So gender distribution, more female, 71%, mostly Caucasian, 53%, only 1/3 Asian. For the pediatric Moyamoya disease patient, 73% of them had direct bypasses, and in the adult, 96% of them had direct bypasses. So when we do the univariate analysis, looking at all the different risk factors that we could potentially correlate with the bypass stroke risk, this is what it comes up with. The p-value is when there is a statistical significant differences for the risk factors that we studied. So we can see for age categories, so the older the patient, the higher the stroke risk. You can see, so for pediatric population, 2% major stroke risk. For over 60 years old, 20% major stroke risk. And then if you're over 40 years old, 11% are the risks. So ischemic presentation, higher stroke risk. Headache, for some reason, it's got the without headache has got a higher stroke risk. Now, diabetes and hyperlipidemia. So with diabetes, higher stroke risk. With hyperlipidemia, higher stroke risk. Now, these are the different score now. Suzuki stage, you can see higher Suzuki stage. There's also a trend. And then for angiographic score, it's a score 1, 2, and 3. Just stenosis, IC-IC collateralization, and EC-IC collateralization. So 0, 5, 15% increased stroke risk. MRI score. So if they have a recent stroke, meaning infarction within 30 days of bypass, stroke risk after a bypass would be 36%, so very high, 1 in 3. And then hemodynamic reserve score. So if you have a still phenomenon, 22% stroke risk. And if there is impaired reserve, so there is 6% stroke risk. If there is no impairment at all, very, very low, less than 1% stroke risk. You can see types of bypasses, direct versus indirect. There's a trend, but the numbers are clearly very different. So very few indirect bypasses. So those are the univariate analysis, but ultimately there will be confounding factors. And in order to take into account all the confounding factors, we do this logistic regression analysis. And we find that the factors that are still statistically significant will be the age, still at 0.025, and then angiographic score, modified MRI score, and hemodynamic score. So everything else that we see from the univariate analysis is no longer statistically significant. As you can see here, Suzuki stage, not anymore. We also put in the bypass type, and even though it's this trend, but there is no statistically significant difference here. And this is now, therefore, the newly proposed Stanford-Berlin Moyamoya grading system, where we take into account a patient's age and assign them scores, the angiographic finding in 3 simple categories, MRI finding in 3 categories with positive DWI infarct, within 30 days of bypass, getting 2 points, and then the hemodynamic reserve score, regardless of the modality imaging to assess the hemodynamic reserve. So you can see for this, so there will be a total of different numbers of scores, and I'll show you the applicability in a minute. So for this area under the curve, this is essentially to see how good is this correlation between the proposed model and the stroke risk. And area under the curve of 0.85 shows good correlation. So anything more than 0.8 and above is considered good correlation. So there's clearly good correlation. And you can see that the higher the score, the blues are the patients who had strokes. Higher the score, the higher the stroke risk. And you can see that based on the simple eyeballing, up to 6, the risk is considered very low. 7 and 8 will be considered moderate risk. 9 and above will be considered high risk of stroke post-bypass. And in simple terms, you can even think of it as less than 5% if the score is up to 6, so up to 20%, and more than 20% if the score is 9 or above. So will this still hold up on the validation cohort? Now, based on the validation cohort, we know we used the data from 2015 to 2018, again, still from Stanford, so nearly 300 patients, and this is what we see. There is already a pitfalls here. You can see the number of patients less than 18 years old is very low, so there's already a problem here, because we didn't include a lot of PEDS patient, but and then the older patient, again, low numbers. But there's a trend there. So the p-value is 0.11. For the angiographic score, so whether it's 1 or 2, there is no difference in the stroke risk, and this one doesn't come out as statistically significant. With the MRI score, if there is a recent infarct, 20% risk of stroke, so the p-value is still valid. And the hemodynamic score, if there's still phenomenon, 20% risk of stroke. So again, the hemodynamic reserve score is still valid. Now, if you look at the area under the curve, the correlation is 0.76. So that shows moderate correlation, not as good as the derivation cohort that we have. But there's still a trend that you can see up to score of 6. Stroke risk is up to 5%. Stroke risk of 7 and 8, score 7 and 8 up to 20%, and score 9 and above would be above 20% stroke risk. So that's certainly the we still think there's good reason to use this Stanford Berlin Moyamoya grade, and we can stratify them into 3 groups up to 6 point, and then 7 and 8 as the moderate group, and 9 point and above as the high risk group. So what about machine learning, predictive modeling, and if we employ the machine learning, will it help us? So with the machine learning model, I used one of our statisticians from Johns Hopkins. So he incorporated all the patients that we have, over 1,000 patients, with a 78 event rate, and then these groups are now split into the training set and a testing set with the 70-30 split. This is in order to allocate the 30-day stroke risk proportionally in both the groups. So with the very clever computer system, they were able to normalize the predictors and data imputation and dimensionality reduction. So these are all very clever stuff. So I was reassured by the statistician that these are all valid methods. Now, in terms of the regression model, there are 2 models that we tried out, the Lasso regression and the gradient boosting machine regression models. So in simple terms, gradient boosting machine model, essentially it's a type of machine learning where it builds on successive, they call it trees, shallow or weak trees. So each time the machine tries to learn on the previous case, and see if there is anything that can learn from the previous model and then improve for the subsequent one in order to improve the accuracy of the model itself for the final end product. So it says that when combined together, this many weak successive tree produce a powerful committee in order to have a very strong prediction for the post-op stroke risk. And this is the model that we go with, the gradient boosting machine model. And with this model, it came out that the 4 factors that has got the highest predictor for stroke risk are the MRI score, hemodynamic score, age at first surgery, and the angiographic score, which is essentially the same 4 factors as we saw in the Stanford Berlin Moyamoya grading system. The rest are not as strong. So with these models, how is it in the testing set? So in the test set, they can achieve an accuracy of 93%. So it says here with the model, it's 93% accurate to predict if patient could have a stroke or not. So it's not the best, but good enough. So at the moment, you can see that it's very specific. So if you say that you're not going to get a stroke, then there's a high chance you won't get a stroke, but it's not very sensitive. So there's certainly more room for improvement based on what we can see here. So this is therefore the newly proposed Stanford Berlin Moyamoya grading system that incorporate the 4 factors: the age of the patient during bypass, the angiographic score, the modified MRI score, and the hemodynamic reserve score. So age, 4 groups, less than 18, up to 40 years old, 40 and above, more than 60 years old. So the scores increase as the groups age get higher. Angiographic score, as I say, the 3 types, only steno-occlusive disease. If the patient has IC-IC collateralization, they get a 2 point. If they already have pre-existing EC-IC collateralization, they get 3 points. For the modified MRI score, If it's no infarction, ischemic changes, or bleed, no point. Any all infarct or all bleed or atrophy, we get 1 point. New infarction within 30 days of bypass, get 2 points. And hemodynamic reserve study, the 3 groups: good augmentation, impaired, where there is no improvement to the blood flow, or still phenomenon. So therefore, we can see that using this Stanford Berlin Moyamoya grading system, the post-bypass stroke risk could be stratified into 3 groups: the low-risk group with the Stanford Berlin Moyamoya grade less than 6 or SBM less than 6, moderate risk SBM 7 to 8, or high risk SBM more than 9. There's certainly still room for improvement. We know that the numbers are not high enough. There is still certainly bigger cohort of patients that's required. We need multi-center validation, because ultimately this is based on Stanford cohort that we have done the derivation and the validation work. But we need worldwide collaboration, especially groups from East, like yourself, from China, Japan, Korea, where there will be a lot of more numbers to see whether this grading system would in fact stand the test of time and be applicable for our patient cohort. So once we have all the bigger cohort, then we will be able to work with the predictive modeling and improve the accuracy further. So now we're working on the machine learning. Perhaps we might even have to rely on the computer itself, the machine learning itself, artificial intelligence, to grade the different groups rather than humans subjectively grading them. So this is a collaborative work, like I say, including a lot of people that has helped me along the way. And these are the names. Thank you very much.
Thank you. Thank you, Maria. So, you know, the big problem from China is that we don't have the DIMOX.
Yes.
Yeah, that's a main problem, that we couldn't get the HDR score.
Yeah.
Yeah, that's the main problem.
Mm.
And actually, according to my own experience, the age score was not so significant different, you know.
Mm. You mean in terms of the stroke risk? So you don't think there's a difference between a younger patient and an older patient with the post-op stroke risk?
Yes, I think the peri-operative complications still mainly depends on your understanding of the hemodynamic changes before the surgery. Yeah.
Yes. Yeah. No, I think that's a very valid point. I'm sure. Perhaps the population could be slightly different, because I know from China there's a lot of patients. There was a paper, I remember, like a registry paper, the Chinese registry, that look at patients who had bypasses. In fact, I would say maybe 70–80% of patients who are diagnosed with Moyamoya do not get bypasses in China, if I understood it correctly.
No, we don't have the DIMOX for more than 20 years.
Yeah.
Yeah.
But I'm just saying the patients. So if a lot of patients don't get bypasses, so perhaps the patient selection in China is quite stringent. So you're quite strict in selecting who you're going to offer bypass to.
Actually, I already have more than 9,000 cases for bypass. Yeah, and I don't think the age means so much in this score. Yeah.
So what do you think would be factors to be taken into account, and like based on your 9,000
the high risk is
experience?
I think the highest risk is some patients that have some TIA.
Like
attack.
active TIA.
Yeah. Active
that's
TIA.
right.
That's the most dangerous.
Yes, that's right.
Yeah.
Yeah, that's true. But with the still phenomenon, because you never studied it, so
yes, we only have some SPECT or perfusion, CT perfusion, MR perfusion, and the SPECT.
Yeah.
This, so we couldn't measure how,
No,
the
no.
steer phenomenon. Yeah.
That's right. That's right.
Yeah, that's a problem. Yeah.
Okay.
So actually, you know, this grading system it's not very practical in China, you know.
That's right. That's right.
Sorry, Martin Woodley here. I still don't have a camera here because of bandwidth and desktop. But hi, Dr. Bin, Professor Bin Shu. So
hi.
I want to just ask the Dr. T, or what. I get a little bit confused here. What are the time frames? Like, what are the follow-up periods? And within what time frame he's talking about perioperative stroke?
Oh, I see. Sorry.
He's saying, you know, the patients who get a stroke within 30 days, they are at high risk. High risk what? They already had a stroke after 30 days. So now to get another stroke, and then within what time frame? Because there's a natural progression in this disease.
Okay. Understand. So I didn't make myself clear. So the two things. So before we knew about this, I mean, when, let's say, more and more patient coming with a stroke, then there is a natural instinct to say, oh, well, patient's actively stroking out, therefore we should offer them bypass quickly. So previously, so I would say before 2014, Professor Steinberg in Stanford is very keen to offer the bypass as soon as possible. So that normally means if a patient admitted with a stroke, with a Moyamoya disease diagnosis, the bypass will be done within 2 to 3 weeks, within 2 to 3 weeks of them having a stroke. So then he found out that actually this group of patients, they do poorly because perioperative stroke risk normally means 30 days after the bypass. So if you have a stroke 30 days prior, then your risk of having another stroke within 30 days after your bypass is very high. So I think this is what
sounds very logical. Yes, that sounds very logical.
Yes.
You would expect that. Yes,
that's right. But I mean, before we didn't have this information. Then we were offering patients early bypass with the view to minimize the stroke risk. But what we do know, what we know now is that if they have a stroke within 30 days, then we let them rest or we let them cool off for about 4 to 6 weeks before we offer the bypass surgery. And this is our current practice. And as a result,
we also wait six weeks. Yeah.
Okay. So Professor Xu, then what you I mean, you've got a huge clinical experience, and so you probably don't need a grading system to assess what is going on. But
No. I still need the grading system. Okay. I will explain further for you. You can see according to the DSA, actually the grade the score 3 means some spontaneous stoma was already formed from ECIC. Spontaneous stoma already formed. Actually, this is a good sign for me, but not negative factors. You know, this means the cortex already have some hypoxia, and this ECIC spontaneous collateralization actually means the greater potential to form the spontaneous stoma after EDMS, after the indirect procedures. You know, so I think the Suzuki's grading system is still very useful because, you know, the late stage of Suzuki grading system, like stage 5 or stage 6. This means that this kind of patient already have some spontaneous stoma
Right.
means greater potential to do the indirect procedure. So if you use combined procedure, STMCA bypass combined with EDMS,
Yes.
you can get a very nice
result.
Very nice effect, you know.
Well, along these lines.
So for me,
so
the
3
score for
the
this
more
DSA
important
funding,
or the
I think
TIA?
it's not a very reasonable.
Okay. Sorry. So when we talk about these strokes, is it really only flow, or is the TIA that may occur in these diseased vessels and stuff? Is the TIA very important? What do you think?
Yes, the TIA, especially preoperative TIA, is a very dangerous sign. Actually, the active TIA is means the condition of the hemodynamic was not very stable, and actually when you do the direct bypass, actually the watershed shift is definitely happened because of the pressure balance was rebalanced between the ECIC territory. Yeah. So this, if you have active TIA attack, it's quite dangerous. So normally we will give some medicine to the patient, and if the patient is stable, then we perform the bypass.
Okay, thank you.
You're welcome.
I have a question about the DSA score as well, if that's okay. I guess for both of you, Dr. Teo and Dr. Bin. I'm particularly interested in the group 3s, the ones that have the spontaneous ECIC collaterals.
Yeah.
Dr. Teo, were you able to look back on your series and say, you know, the ones that did have a stroke, is that because the collaterals were not recognized at the time of surgery and therefore the craniotomy might have taken them down? And, you know, could you have desired, you know, is it down to technical factors, or is it the fact that the grade 3s are a surrogate for more severe disease?
No, totally right. I think this is learning from our past experience. You know, like traditionally when we learn to do the bypass, I know Professor Shipping do it differently. I see the kind of wrapping, I think he called it spring roll techniques, that he will wrap the dura around the middle meningeal. Whereas when we do it in Stanford, you know, we just cut it across. So yes, perhaps in some cases, you would have sacrificed the spontaneously existing ECIC collateralization, and that led to the stroke risk of the area that needed the collaterals. Yeah, so that's definitely one possibility. But I think the other possibility is it's a surrogate marker of disease severity. I'm pretty sure that's the case. And so now when I do the bypasses here in the UK, so I take that on board, and a lot of the time, if I see a big ECIC collaterals, then I will spare the bone flap and not to incorporate them at all. So I wouldn't be as brave to expose it. I try to spare the move the craniotomy somewhere else. And
that I guess if you reanalyze your data in the future, then the grade 3s might disappear from the
exactly right.
Model, right.
So yeah, so I think this is a preliminary work. So there are certainly room for improvement. And if you remember the gradient boosting machine learning model, it listed the 4 factors. So the one with the strongest factor is the MRI finding. The second strongest is the hemodynamic finding. The third and the fourth are the age. So perhaps it's just like Professor Shipping said, you know, you need to weight them instead of just assign them 1, 2, 3, 4. You have to weight the factors accordingly. And then I remember when I look at the validation cohort, the angiography finding didn't even become valid at all. You know, so you thought, oh, maybe it doesn't even matter what sort of angio finding you are for the stroke risk. And I guess that's to do with having realized the things that we have learned from the technical imperfection in the past, and is no longer relevant, you know, because you can avoid them now.
Right, thank you.
Yes, normally the the middle meningeal artery is the main source of the ECIC spontaneous stoma. So we have to protect the MMA. So sometimes I do two craniotomy, one in front of the MMA, then one posterior to the MMA. Yeah. So you can keep the bridge over the MMA.
And you're doing that so that you don't even risk the craniotome going across it, essentially.
Yeah, actually, may I share my screen? Yeah, I can show you. Actually, this is I called it the throat principle of hemodynamic change of Moyamoya. This is just like a throat. So this is a hemodynamic change before and after the. This is a Moyamoya syndrome. So one of my colleagues, they put a stent into the M1, and you can see after the recanalization of the M1, now the Moyamoya vessel disappeared almostly. And if you see backward to from DCBA, actually this is the formation procedure of Moyamoya. So this is all my hemodynamic analysis for the Moyamoya bypass. So you can see this is some spontaneous stoma from middle meningeal artery. You can see the blood flow was abundant, but in my personal series, only less than 20 cases was unnecessary to do the bypass or EDMS. So most of the late stage of Moyamoya still need the bypass. You can see this spontaneous stoma actually feeded the contralateral frontal lobe such a long way to feed the contralateral frontal lobe. So we have to protect the middle meningeal artery, and this is MMA also can be originated from like ophthalmic artery. You can see this is originated from ophthalmic artery, but not from ECA, not from the maxillary artery. So this is how I protect the. So this is the middle meningeal artery. You can see I do the two bone window, one in front of the middle meningeal artery, one posterior to the. Actually, you can see some blue line at here under the bridge. So I think the best protection of middle meningeal artery is keeping the MMA, MV, and the covered bone complex. Sometimes they use a single bone flap combined multiple hole. And you can see the middle meningeal artery was running in MMV like this. So I use like this Chinese spring roll technique to protect the MMA. At the same time, to stop the bleeding from MMV. So this is how I do it.
So you're saying, can I ask a question?
Mm-hmm. Yeah.
So you're saying you would protect the MMA regardless of whether there is already collateral spontaneously into the brain. Is that right?
Yes. If there's a spontaneous stoma, every stoma should be kept intact.
No, but if there is no spontaneous stoma, because you say if there is spontaneous stoma,
sometimes we can do the EMS directly, but not the EDMS. It's a similar effect. But if it's already formed some spontaneous stoma, yeah, we will always keep it.
So how do you decide then to do the 2 separate bone flap or the bone flap exposing the middle meningeal?
According to the preoperative DSA, because the ECA was already always perform the angiogram separately. So every case we can, because I both doing the open surgery and the endovascular treatment. So every case we will perform the angiogram by ourselves.
Right. So what is it, because the extent of the spontaneous collaterals that make you decide which way to go? Like how, what I still can't understand how do you decide? Was it, you're gonna do 2 bone flap or just single bone flap?
It depends, if I actually, I can show you the bone, the skin incision. No, sorry. So this is you can see this is a different scalp flap according to the anatomy of STA. So like this one, you can see according to the preoperative DSA, the parietal branch of STA already formed some spontaneous stoma with the cortex. So I use this flap to use the temporal frontal branch of the STA to do the direct bypass combined with the EDMS. And this is a hemorrhagical type, already performed the drainage of the ventricle. So actually, according to the DSA, there's already have some spontaneous stoma around this borehole. So we also keep the middle meningeal arteries main branch and just do one single bone flap posterior to the MMA. And like this patient, it's a very extensive ischemia for both for all the 4 temporal, 4 frontal lobes, parietal lobe, occipital lobe, even temporal lobe. So we do a very extensive bone flap under the scalp flap. This is this patient already formed the spontaneous stoma of MMA, and you can see I use the parietal branch of STA and the occipital artery to do the double bypass combined with EDMS. And this is a typical middle meningeal artery. It's already very thick, so I do a bone flap according to the preoperative angiogram. So this is the middle line was all formed, the spontaneous stoma from middle meningeal artery. Even the parietal branch or frontal branch formed the extensive spontaneous stoma. We still can find some space to expose the cortex artery and do the direct bypass like this.
Okay, thank you.
Mm-hmm. Okay, any questions?
Okay, it's good interaction, Ben.
Mhm.
No, that was very good, Professor Xu and
Mhm.
Dr. Chow. It was really lovely information that you're passing on here. Thank you.
Thank you, Martin.
Pleasure, pleasure.
Very good, Ben. I guess we'll move on. Do we have the schedule for next in 2 weeks yet? I don't know if Juan Lee is still there. Are you still there, Juan Lee?
Yes, yes, yeah. We are planning for the next webinar. Yeah, after 2 weeks. So if you have any speaker you want to recommend, yeah, we will.
Yeah, I have some. Is there anything? We'll talk later, but if there's someone special
Yeah,
you want, we
so
can get that. If there's something you
Yeah.
want, we'll get them.
Yeah. The time schedule is fixed. 2 weeks. I mean, Sunday afternoon, Sunday
Yeah,
evening. So
the same time.
that will be July 15th, right? Nope.
No, just 2 weeks from today. No, it's middle of June.
Yes.
Yeah,
Should be June.
June 14th.
Yeah,
No.
we'll communicate.
June 12th. Oh, yes.
June 12th. Okay, I'd like to thank Lee Ma, Sir Mario. Thanks,
Yeah.
Takashi. Thanks, Martin, for your commentary. And of course, thanks, Ben, for putting this all together. And we'll see you in 2 weeks.
Another thing,
Excuse me.
Mario.
Yeah,
and
Mario.
Martin,
Yeah.
Yeah. I
Long
think
time no see.
Long time no see.
I think the vein is also very important. You know, we not only focus on we not only focus on the artery side of the hemodynamic changes, but actually the vein side, they also have a lot of a lot of change of the hemodynamic change, and it's very complex. And sometimes I can show you some. I can show you some change of the vein, and you can see.
Yeah, I think these veins are really very important, because ultimately when you want to augment blood flow, you need to have an outflow. I did a lot of work in the Professor Yazagir's laboratory at the time, and really an anastomosis doesn't really work very well unless you have a pressure gradient. We all know that. So
yes, that's correct. So,
and the Moyamoya disease is exactly that. That's the problem. There is a complete. I don't know how to describe it. It's like a sponge that is clogged somehow, and so the inflow pressure would have to be very high. And so
yes, Martin, you can see this picture, and Maria, you can see. Actually, this is the bypass, and this is a donor artery. This is a recipient artery, and you can see the this is a vein beside the cortex. Yeah, you can see the turbulence in the vein, and both side turbulence, and actually in this segment, the blood flow was almost stopped. Because at the two ends of this segment, the balance, the pressure is almost balanced. So the delta P between these two ends is very small, and the blood flow is very slow. But actually, this side and this the pressure in this vein is quite high, increased a lot. So this may cause the other side of the cortex. Actually, the drainage to this vein, there's some problem, because the vein in this side, actually the pressure in this vein is elevated a lot. Maybe even too high to the navel cortex. So main cause some infarction. So you know a lot of complication for this after operation complication is the navel cortex infarction, but not the cortex who get the direct bypass.
Okay.
Yeah, makes sense. Yeah.
Yeah.
Okay, so 你们大家好 and 再见了。还有一个会。
Okay, great. You can see, you can
你
say
们中国人
Chinese.
明白啊？Okay, 再见了。
Okay, 再见。
Okay,
再见。
I
bye bye.
understand what you guys are saying.
Bye bye.
Okay, we'll see. Are we all set there, Ben? I don't want to close early again.
Okay, okay.
We all
Yeah,
set
actually,
Thank you.
Maria, I think Dr. Kang also here, and I think he want to
Oh,
say
okay.
hello to you, but I'm not sure if he is still
Who?
Let's see.
Dr.
online.
Contract.
Kang Shuai, yes, yeah.
Kang Shuai. Oh,
Kang
okay,
Shuai,
okay.
yes. You're
Yes,
in San Francisco
Yeah, that's right. We were in San
Together.
Francisco together. Yeah, that's
three
right.
or 4 years ago, right?
Oh, longer. 2014. So
Oh, so 6 years ago.
more than that. 8
Wow.
years ago now.
Oh, 8 years. Wow,
Yeah.
yeah.
I don't
Time
Yeah, I
flies.
think Kang Shuai, yeah. 8
Kang
years
Shuai.
ago, a long time.
Yeah.
Okay. So how's that in UK? Everything okay, right?
Yeah, pretty good. Thank you. Pretty good. So the Moyamoya, we still a lot to learn because ultimately the knowledge is coming from the East. But the Western patient, like in the UK, before I come back, very few patients get bypasses because the preconceived ideas is that bypass is too high a risk for surgery for patient, you know.
Oh.
So the point of doing bypass for them if you're gonna cause a stroke afterwards. So I think part of the reason I do the work is to show that actually they're not all the same for every single patient. And there are patients where the post-op stroke risk is low and it's acceptable to offer them the bypass surgery in order to have long-term protection from the Moyamoya disease, you know, because we know the natural history is such that they will almost certainly get a stroke, because the natural history is always quoted in the region of 8% or so per year of stroke or bleed risk. This is based on some old series. I'm sure there are some new studies that needs to be taken into account.
Yes, Moyamoya is the most complicated disease in all the vascular disease. Yeah.
That's right. That's right. So there's still a lot to learn for sure. I think the
Yeah.
vein one is a very interesting one. So maybe the grading system needs to take into account of more factors, you know, like
Yes.
so
Yes.
there's a lot more to be learned, a lot more to be learned.
Okay.
Okay, should we wrap it up, Wan Lee, or you got more, anyone else?
Yeah, I hope everything return to normal and we can do international traveling as
Okay, pretty soon. And
Yeah,
okay, then thanks everybody, and we'll see you in 2 weeks.
Okay.
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 Thank you.
Bye-bye.
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 Thanks for the invitation.